Okay. Okay, so welcome to this Predictor series for the NICT. Let me just check my device. Okay, yes. Okay, the chat box is open in front of me, and I can see the video as well as this voice is going good. Okay, so should we start? 10 questions. We'll quickly revise all of these things you know already. So let's see. NICT Predictor series. 10 questions. Out of these, 3 are multiple answer type and 7 are single best answer. There are image based questions also in this. Okay, good evening, Angelo. Okay, so let's start with the first question. 45-year-old female, 1 day history of right upper quadrant pain and tenderness, nausea, vomiting. Marked right upper quadrant tenderness and guarding. Laboratory value says WBCs are high. 10% band cells are neutrophil, again suggestive of some inflammation infection. Total bilirubin is towards the higher side. Right upper quadrant reveals, ultrasound reveals gallstones and a thickened gallbladder wall and a normal common bile duct. Okay, so what do you think is the diagnosis? Tell me the diagnosis quickly. What is the diagnosis? WBCs are high, there are several gallstones and the thick gallbladder wall. CBD is normal. So this is acute calculus cholecystitis. Acute calculus cholecystitis. So in acute calculus cholecystitis, the investigation of choice is ultrasound only. But if they ask most sensitive investigation, that is HIDA scan. On HIDA scan, you will see that the gallbladder is not filling, absence of gallbladder filling. What is the optimal management of this patient? What is the management? Okay, the patient is just 1 day history. So the female, she had come in 24 hours. So let's see the options. Schedule for outpatient laparoscopic cholecystectomy. Okay, elective means you will discharge the patient from emergency, call her in the OPD, and then you plan for this. Admit, give IV antibiotics, laparoscopic cholecystectomy within 48 hours of admission. Admit, give IV antibiotics for 4 to 5 days, followed by laparoscopic cholecystectomy. And keep giving antibiotics till the WBCs become normal, followed by elective laparoscopic cholecystectomy kind of interval. So what do you think should be the answer? Acute cholecystitis within treatment of acute cholecystitis depends on when the patient is presenting. Within 48 to 72 hours, mostly 48 to 72 hours of the symptom of the onset of pain. And the treatment is different if the patient comes after 48 to 72 hours. Okay, so if the patient comes within 48 to 72 hours of the onset of pain, then the treatment is surgery. Go for surgery, go for laparoscopic cholecystectomy. These days the guidelines are in the first 48 to 72 hours, you can go for laparoscopic cholecystectomy. It will be a bit difficult than the usual elective cholecystectomy, but still in most of the cases it is feasible. But when the patient comes after 48 to 72 hours, okay, what will happen after 48 to 72 hours? Suppose this is the gallbladder which is inflamed. So in this 48 to 72 hours, there will be different, at this part the omentum will come, the intestine will come, and it will form a kind of phlegmon or mass. And now if you want to go for the surgery, it will be a very difficult surgery. In fact, you might cause injury to something. So that's why now what you will do is you will go for conservative management. Conservative management means you will give this IV antibiotics, painkiller and all, and do a laparoscopic cholecystectomy, elective laparoscopic cholecystectomy after 6 to 8 weeks. Okay, so this is the treatment difference between whether the patient is coming in the initial 48 to 72 hours or the patient is coming later. So going with these things, let's see option number B. Admit, give IV antibiotics and laparoscopic cholecystectomy within 48 hours of admission. Okay, so this is the correct answer. Anybody, if you want to ask anything, any confusion, anything, please, you can clear your doubts. Okay. Next question. 45-year-old man found to have a palpable neck mass on the physical examination. Thyroid ultrasound shows 2 by 1.4 centimeter right thyroid nodule. How is radical different from extensive cholecystectomy? See, the Shagufta, there is nothing like, there is no term like extensive cholecystectomy. Okay, there is either a simple cholecystectomy, which can be open or laparoscopic, in which we remove only the gallbladder, or there can be radical or extended cholecystectomy. Extended or radical is almost the same thing. In that case, we will remove along with the gallbladder the lymph nodes in that area and also a part of the liver, which can be a 2 centimeter cuff or the segment 4A or segment 4B or 5. Okay, Shagufta. Fine needle aspiration was performed and shown the following picture. Okay, so what is this picture on FNAC? Yes, it is medullary thyroid cancer. This is medullary thyroid cancer. Okay, amyloid stroma. Amyloid stroma. Genetic testing was performed and positive for germline red proto-oncogene mutation. Serum calcium and parathyroid hormone levels are checked and both are within normal range. What is the most appropriate next step in the management? What is the most appropriate next step in the management of this patient? Measure thyroid stimulating hormone level TSH, measure thyroglobulin, total thyroidectomy, measure urine or free plasma metanephrine level. Patient is having medullary thyroid cancer and red gene positive. Okay, so what is coming into your mind? What do you want to rule out in this case? Medullary thyroid cancer, red gene, it could be a MEN syndrome, MEN 2A or 2B. So in MEN 2 syndrome, one very important thing which can be seen is pheochromocytoma. And if there is pheo, you have to deal with pheo first. So that's why measure the urine or plasma free metanephrine level. Yes, rule out pheochromocytoma. All of you are correct. Thyroglobulin level is not going to be of any use in case of medullary thyroid cancer. Here serum thyroglobulin is not the tumor marker. Here the tumor markers are calcitonin and carcinoembryonic antigen. Treatment in medullary thyroid cancer, you'll always go for, after ruling out pheo, total thyroidectomy with routine bilateral central node dissection. And if lymph nodes are present, you need to go for MRND. If it is not present, you can leave it. But routine central compartment dissection you have to do in these cases. Okay, so I guess it is very clear, straightforward, but very important question. Okay, should we move to the next? Which one of the following cases is considered a clean contaminated wound? So there are 4 options. I want you to tell me what are these wounds. Open cholecystectomy for cholelithiasis. Tell me, as per the WHO classification for the surgical wounds, this comes under which? Tell me, you can write as A is what, B is what, C is what, and D is what. Open cholecystectomy for cholelithiasis. Okay, there are clean, contaminated, and dirty. 4 types. So tell me, what is this? This is class 2, that is clean contaminated. Herniorrhaphy with mesh repair. This is 1, clean. Lumpectomy with axillary nerve dissection. This is also 1, clean. Gunshot wound to the abdomen with injuries to the small bowel and sigmoid colon. Sigmoid colon injury. Sigmoid colon, there will be fecal matter will come out, leading to fecal peritonitis. Fecal peritonitis. So this will be type 4, dirty. Type 4, dirty. Okay, contaminated. Most of you, many of you are calling it what does comes in 3? Contaminated. Contaminated is when there is gross spillage from hollow viscera. Gross spillage from hollow viscera. Major breach in the sterility, like open cardiac massage. This was asked in the INICET last year. And there is, if there is early accidental wound. Early accidental wound less than 24 hours. So these things comes under contaminated wounds. Okay, so the answer is clean contaminated. It is option number A, open cholecystectomy. Option number A, open cholecystectomy. Okay, any doubt if you have in this topic, in this particular topic, because recently asked question, you should clear it. Anything, any doubt, anybody in this WHO classification for the surgical wounds? So answer is A. Moving to the next question. 56-year-old female diagnosed with a 4 cm invasive carcinoma of the breast, which is triple negative. Triple negative means ER, PR, HER2 new negative. That is not a good type of cancer. Tumor invades through the skin, causing ulceration, which is shown in the image. Can you see there is this ulceration? And she has a palpable right axillary lymphadenopathy. Okay, so what is the, tell me if you know TNM staging. Staging for the metastatic disease is negative, so I'll write M0 here. Palpable right axillary lymph nodes. Let me give you another hint, it is mobile. Hello. Now you tell me. Percent, Vishal, you want to know percentage of infection clean, less than 2% clean, contaminated 2 to 10%, contaminated 15 to 20%, and dirty 30 to 40%. I mean, this is the risk of infection in the wound as per this. Okay. Okay, so yes, you are saying yes, T4B, yes, correct. Mobile N1. T4B N1 as per the stage, this comes in which stage? Anybody? 3B. 3B is locally advanced breast cancer. We call it as inoperable. I mean, at this moment, it is inoperable type of LABC. So in this case, what will we do? If it is currently inoperable, you go for neoadjuvant chemotherapy. Okay, so there are two options of neoadjuvant. Upfront mastectomy means without neoadjuvant chemotherapy you are going for mastectomy. No, first you have to give neoadjuvant chemotherapy. No need of palliation. The patient does not have any distant metastasis. So out of these two, our answer should be neoadjuvant chemotherapy followed by mastectomy with axillary lymph node dissection and post-mastectomy radiation. Another is without radiation. So tell me, one is radiation, A is with radiation, B is without radiation. You want to give radiation in this case or not? Tell me the answer, whether radiation is required or not in this case. Yes, you want to give radiation, so this will be option number A. Radiation is given to all LABCs. All LABCs. Yes, Umesh, you are correct. But what about radiation? Radiation you have to give. Radiation we need to give to the patient. Okay, so yes, A is the correct answer. A is the correct answer. Okay. Next question. A teenage boy falls from his bicycle and run over by a truck. On arrival in the emergency room, he is awake and alert and appears frightened but in no distress. The chest radiograph suggests an air fluid level in the left lower lung field. This is, you can see the air fluid level in the left lower lung field. And the nasogastric tube seems to coil upward into the left chest. The next best step in the management is, tell me the diagnosis. What is the diagnosis in this case? Anybody? After the blunt trauma, there is this kind of X-ray is seen. Okay, this is the thing. What do you think is this? Air fluid level. And the nasogastric tube seems to coil upwards in the left chest. You try to put a NG tube or Riles tube and it is going in the left chest. So tell me, what is the diagnosis in this case? What is the diagnosis? Yes, you're correct. Diaphragm injury. This is very classical of diaphragm injury. Hemopneumothorax. Hemopneumothorax can give this picture, but in hemopneumothorax, your nasogastric tube will not coil in the left chest. Nasogastric tube will go normally in the stomach. Okay, so this is a diaphragm injury. So what will you do? What is the best step in the management? Placement of a left chest tube, that is something which you should not do. Okay, this was again INICET question. Should not do. Thoracotomy, laparotomy, and esophagogastroscopy. Esophagogastroscopy is basically upper GI endoscopy. Okay, so there is no role of endoscopy as such in the diaphragm injury. This is something you should not do. Now the approach can be diaphragmatic injury, although you can approach through thoracoscopic route also, VATS, laparoscopy, but the preferred route is abdominal. So laparotomy is the answer. Laparotomy is the answer. Yes, for best thing is you can go for a diagnostic laparoscopy if there is any diagnostic dilemma, but surgery is the only treatment. Okay, surgery is the only treatment in the patients of diaphragm injury. There is no conservative management. No conservative management. Okay, so I guess this is also clear. Okay. Should we move to the next question? Okay, this might be a bit, you might find a bit difficult. 65-year-old female found to have microscopic hematuria on urine analysis done for a basic physical workup. A follow-up cystoscopy show a low-grade TA bladder tumor. Okay, this is non-invasive papillary tumor. This is TA is non-invasive papillary tumor of urinary bladder. What is the appropriate treatment? These are the options in front of you. Tell me, anybody has any idea what we do in these cases? Okay, so bladder tumor, if it is TA or TIS. Okay, TA is non-invasive papillary, TIS is carcinoma in situ, or if it is T1 involving the mucosa. These are known as non-invasive bladder tumors. Non-invasive. Okay, all of you are saying A. Let me correct all of you. Now listen to me. Okay, the questions which you know is fine. Otherwise, now listen to me. Non-invasive. See, what will you do after this? TURBT, transurethral resection of bladder tumor, and you will give one instillation of intravesical mitomycin, one dose of intravesical mitomycin post-operatively after the surgery. Listen to me now. Yes, Subha is correct. After this, see, when you do a TURBT, actually, then only you will know exactly that what is the staging. So TURBT is more of, you can say, rather than therapeutic, more of a diagnostic thing. When you do TURBT, you will know how deep it is going. So now you will see, if it is TA, now you can say low risk and high risk. If it is TA and low grade and less than 3 centimeters, you follow up. High risk, if it is TIS, if it is T1 or TA with more than 3 centimeters or high grade. In these cases, you have to give intravesical immunotherapy. Okay, so giving mitomycin is chemotherapy. Now in these cases, you have to give intravesical PCG weekly for 6 weeks, followed by 3 weekly for 6 months. 3 weekly for 6 months up to maybe 3 years. Okay, so in these cases you will give intravesical BCG. Our question says it is TA and low grade, so that's why only mitomycin. Only mitomycin. Somebody, Subha is correct. TURBT followed by intravesical mitomycin. Okay, more than that, if it involves some detrusor muscle or perivesical fat, that is T3, or it goes outside, T4. In these cases, first you give neoadjuvant chemotherapy and radiation, followed by radical cystectomy. Okay, so this is in short the management of urinary bladder tumor. So option number D is correct. If you have any confusion, please let me know. Any confusion, any doubt? The question says it is a low grade TA bladder tumor. Okay, so that's why only mitomycin. I hope it is clear. What is the classic enhancement pattern of hepatocellular carcinoma on cross-sectional imaging with a portal venous, arterial and delayed phase? See, suppose this is a hepatocellular carcinoma on CT. There are, you can, some people they say triple phase CT, few people they call it as 4 phase. So in that triple phase or 4 phase is nothing, but this triple phase they add non-contrast also. So suppose, okay, let me tell you. what will happen? Suppose it is non-contrast. Non-contrast, the hepatocellular carcinoma will look hypodense. Now you will give IV contrast. After giving IV contrast, approximately 12 seconds later, you will take an image that is arterial phase. Around 70 seconds, you take another shot that is portal venous phase. And then around 120 seconds, you will take image that is delayed phase. Okay, so these are, you can say, triple phase, and if you take non-contrast also, then you can call it as 4 phase. So we all know that the liver gets majority of its blood supply from the portal vein, but hepatocellular carcinoma takes blood supply only from the hepatic artery. Hepatocellular carcinoma only from the hepatic artery. So when you give this, when the dye goes through the artery, this will enhance. Okay, it will enhance. Then it becomes decreased, and then there will be washout. Okay, so arterial phase enhancement, let's see. Arterial phase decreased is gone. Okay. Arterial phase increased, portal venous phase decreased, delayed phase persistent washout. Persistent washout. Okay, suppose remove this option and consider it as D. Arterial increased, portal venous decreased, and delayed washout. Equilibrium, what you are saying, Umesh, equilibrium phase is seen in MRI. Okay, that is for MRI. In CT, you will not see equilibrium phase. Okay, Umesh. So C is the correct answer. Yes, all of you are correct. Okay, now let's see some multiple correct type. Okay, these days in INICET, you are getting these question also. This is a very easy question for you. Symptoms or signs of atherosclerotic occlusive disease of the bifurcation of the abdominal aorta. Leriche syndrome includes. Okay, Leriche syndrome means when there is the occlusion at this aortoiliac, you can say call it as saddle thrombus at the aortic bifurcation. Leriche syndrome. Tell me what is out of A, B, C, D, which are the correct options. Claudication of the buttocks and thigh, impotency, retrograde ejaculation, absent femoral pulse. What are the correct options out of these 4? Tell me. Anybody? Okay, so A and B. Claudication of the buttocks and thigh is correct. Impotency is correct. Retrograde ejaculation is not. Absent or decreased femoral pulse is also correct. A, B, D, yes, you are correct. A, B, D. A, B, D is the correct answer. Not the correct response. Yes, A, B, D. Okay. Second last question. Okay. 21-year-old man presents with left testicular mass. Ultrasound reveals a hypoechoic mass. Undergoes left orchidectomy. 4 centimeter mixed germ cell tumor. Okay, so all these things will tell this is non-seminomatous germ cell tumor. Any mixed tumor is non-seminomatous germ cell tumor. The lymphovascular invasion is seen, but no invasion to the spermatic cord. So if there is invasion to the spermatic cord, it is T3. If there is no lymphovascular invasion, it is T1. So this is coming under T2. No lymphovascular invasion is T1. This is T2. Spermatic cord T3, involvement of the scrotum T4. Further imaging, no lymph node or metastasis. So this is T2, N0, M0. It will be stage 1 only. Stage 1 non-seminomatous germ cell tumor. Tumor markers before the surgery were raised, alpha fetoprotein, beta HCG and LDH, all three were raised, and all of these will become normal after the surgery. Which of the following would be a reasonable next step in his care? These are the options. So see, seminoma and non-seminomatous germ cell tumor. Stage 1, 2A, 2B, 2C and 3. Stage 1 is NET, T1 to T4, N0, M0. Stage 2A when there is N1, 2B when there is N2, 2C when there is N3. M0, M1, M2. N1 is less than 2 centimeter lymph node, N2 is 2 to 5 centimeter, N3 is more than 5 centimeter. And stage 3 is when there is M1. Okay, so let's see. In seminoma and non-seminomatous germ cell tumor, after you do a radical high inguinal orchidectomy, what you are supposed to do? Okay, let me tell you again. So as per this is stage 1. Lymph nodes are not involved. Treatment of seminoma and non-seminomatous germ cell tumor, stage 1, 2A, 2B, 2A, 2B, 2C, 3, 2C and 3. So this treatment, the main thing is testis you have removed. Now you have to discuss what you are going to do to the lymph nodes. This staging is TNM staging, humble doctor. This is TNM staging. TNNM, so it has to be TNM staging, no hero or any TNM staging. So what you will do in stage 1, seminoma? Mostly options. You can go for surveillance, I mean just wait and watch, or you can give radiotherapy, or a single dose of carboplatin. 1 dose carboplatin based chemotherapy. 2A, 2B, either radiotherapy or this chemo. BEP is a type of chemotherapy, bleomycin, etoposide, platinum, cisplatin 1. 2C and 3 you have to give BEP1. So now you see the treatment of non-seminomatous is, I told you, this is basically what you are doing with the lymph node because it is radio sensitive. So instead of radiation, in this case it will be surgical removal of the lymph nodes. So stage 1, either surveillance or retroperitoneal lymph node dissection, or we can go for BEP1 cycle. Here retroperitoneal lymph node dissection or BP3. Okay, this is BP3. BP3. This is BP3. 3 cycles. Sorry, 3 cycles. And 2C and 3 BEP3. So can you see the difference mainly lies in this? There we are giving radiotherapy, here we are doing retroperitoneal lymph node dissection. How to decide between radio or chemo? See, this is the preferred treatment, I'll tell you. Okay, this is the preferred treatment, this is the preferred treatment. Out of multiple, these are the preferred treatment. There are options of those things also, but the preferred treatment is this. So suppose you find it difficult to remember, at least remember in stage 1 surveillance, stage 2A, 2B radiotherapy, in this case retroperitoneal lymph node dissection, 2C and 3 chemo. Okay, so this is the encircled one is the preferred treatment and the others are the options. So our question is non-seminomatous germ cell tumor because alpha fetoprotein is never raised in pure seminoma. And this also says embryonal teratoma and yolk sac. So it is a mixed type of non-seminomatous germ cell tumor, and it is only involving the testis, no involvement of the lymph node metastasis, so stage 1. So this comes in this category. Which of the following would be a reasonable next step? Surveillance with repeat imaging, yes. Radiation has no role. Bleomycin, BEP, one cycle, nerve sparing retroperitoneal lymph node dissection, correct. A, C and D are the correct responses. A, C and D. Maybe you find it is as a difficult question, but testicular cancer is an important question for the exam. So A, C and D are the correct response. Okay. Any confusion, you can ask me. Which of the following is true about esophageal cancer? The last question. First line treatment of esophageal squamous cell carcinoma of the cervical esophagus includes transhiatal resection followed by adjuvant capecitabine and radiation. First of all, for cervical esophagus, the treatment is definitive chemo radiation. Surgery is most of the time not done because the surgery will be too extensive. It would be a pharyngo-laryngo esophagectomy, so this option is wrong. And anyways, transhiatal resection is done for lower esophageal cancer. This is cervical esophagus. Okay, so this statement is wrong. This statement is wrong. Percutaneous endoscopic gastrostomy tube should be empirically placed for the nutritional support in patients treated with multimodality therapy. Many times we treat the esophageal cancer patient with pre-op chemo radiation and then we go for the surgery. So when the patient is getting this pre-op chemo radiation, they are not able to eat. How the nutrition can be maintained? Again, this is a wrong statement. You can go for feeding jejunostomy. Feeding jejunostomy is the preferred thing. Why you are not doing a gastrostomy? Because this stomach is going to be used for the pull-up as the esophageal replacement. Okay, so stomach you will use as a esophageal replacement, so you don't want to puncture this stomach which you are going to take to the thorax or to the neck for the replacement. So that's why this is also a wrong statement. Feeding jejunostomy is the better way of giving nutrition. Invasion of trachea is contraindication to esophagectomy. T4B disease, that is vertebra aorta trachea, is inoperable. Okay, vertebra aorta trachea is inoperable. So this is correct statement. In situ and only lamina propria involvement can be treated by endoscopic resection. In situ, yes, TIS, also known as high-grade dysplasia, and this is T1A, only mucosa involvement. So in these cases, these tumors we can treat by endoscopic resection. Endoscopically, you can come and resect this, either endoscopic mucosal resection or endoscopic submucosal dissection. So this is also correct. C and D statement are correct. Okay, I know that you don't find these topics very comfortable, esophageal cancer, testicular cancer, but believe me, these days in surgery, particularly for like INICET and all, malignancy is quite important. Okay, so I would recommend you to read the malignancies more for INICET. Trauma, malignancies, especially like breast cancer and these thyroid cancers, hepatobiliary cancers, these are commonly asked in INICET. Okay, so with this we finish our Predictor series. I wish you all the very best for the upcoming INICET exam. Time will not be a problem. Read the question carefully and see whether it is a single answer or a multiple answer, and I am sure all of you will do well. Yes, I know high level question, but you should practice those high level. There will be few high level questions in the exam, and the INICET is known for this. So if you're going for INICET, you should be a level up as compared to the other people. Okay, so thank you very much, and I wish you all the very best.